Greetings, everybody. Welcome to tonight's Net Smilow Shares. We're going to just wait a minute or two as other folks join, and then I will introduce everybody. For folks just joining, we're waiting a minute before we go ahead and get started with tonight's Net Smilow Shares. All right, well, maybe I'll go ahead and get started just with some introductions. I'm going to share my screen. All right, well, great. Thank you so much, everybody, for joining. We're really all excited to be here. So happy official Net Awareness Day. It is actually on November 10th, which is why we picked this evening. Our goals tonight are to highlight awareness and diagnosis and treatment for patients with neuroendocrine tumors. So I have a wonderful panel of colleagues. My name is Pam Kunz. I'm a professor of medicine and medical oncology. I direct the Center for GI Cancers at Yale Cancer Center and Smilow Cancer Hospital, and I co-lead the neuroendocrine tumor program. Dr. David Klimstra is a professor of pathology, and he will be speaking about understanding your pathology. Dr. George Fakhri is a professor of radiology and biomedical engineering. He directs the PET Center, and we'll talk about PET scans tonight. And Dr. John Kunstman is an assistant professor of surgery and surgical oncology, and we'll talk about surgical approaches to NETs. And then we will finish up with a 30-minute Q&A. All right. So as of 2021, the state of Connecticut recognizes November 10th as Net Cancer Awareness Day. So thank you to Governor Lamont and to a number of NET advocacy organizations for really advocating for this. And so most states acknowledge this day. So I will talk a little bit about neuroendocrine neoplasms 101, and neoplasms encompasses neuroendocrine tumors and the higher grade neuroendocrine carcinomas, and I will talk briefly about some medical management tips. So I love just acknowledging some history here, and some of you may be familiar with the term carcinoid. It was coined by a German pathologist in the early 1900s to describe neuroendocrine tumors, and it meant cancer-like. Neuroendocrine neoplasms can actually start throughout the body. That's called the primary site where it starts. And neuroendocrine neoplasms are derived from neuroendocrine cells in the gut and in other places. Most grow slower than their adenocarcinoma counterparts. Adenocarcinomas are often a more common cancer type. Think of run-of-the-mill colon cancer, for example. And another really key characteristic that I suspect Dr. Fakhri will get into is that somatostatin receptors, or like a target, are usually present on the cell surface of neuroendocrine neoplasms. So NENs are really not that rare. They used to be considered rare. They are low in incidence, meaning the number diagnosed per year, but you can see we're nearing about 10 per 100,000 persons in the US. That's the yellow line. Compared to overall cancers, which is the blue line, which has really stabilized over the last many years. But neuroendocrine neoplasms are increasing. We're getting better at diagnosing them. But there is probably a truth to this line, indicating that perhaps there are environmental reasons or other causes of this increased incidence. NENs are more prevalent than previously appreciated. Prevalence is the number of patients alive at any given time. And the prevalence of neuroendocrine neoplasms is about equal or slightly higher than that of stomach and pancreas cancer combined. There are several key characteristics. I'm not going to go into details on all of these, but when I meet with patients, I talk about these categories or ways that we describe neuroendocrine tumors, whether or not they secrete a hormone, that's called functional status, where the cancer starts, That's the primary site. What's the stage? That means where in your body is the cancer. The volume of disease, is it low volume or high volume? Whether or not you have a somatostatin receptor on the surface of the cell, the grade of the tumor, degree of differentiation. We're starting to look more and more at genetics. So genetics passed from parent to child, and also genetics of the tumor itself. We know that sex and racial differences can occur. And then our environment in which we live can also impact both our diagnosis, but also the type of care we give. Those are called social determinants of health. So the primary site I mentioned already is where the cancer starts. The small intestine is by far the most common, followed by the lung, and then the pancreas, and then other. And if a cancer spreads, it retains the properties of that primary site. So, for example, if a neuroendocrine tumor spreads to the liver, it doesn't become liver cancer. It is still, for example, a pancreatic neuroendocrine tumor that's spread to the liver. We used to be lumpers, but we are really now splitters, meaning that NENs of different primary sites really have different incidence rates, different biology, they respond differently to treatment, and they're often now studied in different trials. So this is a very detailed example of something that we call the AJCC, or American Joint Committee on Cancer staging. And staging helps us determine in three different categories: tumor, lymph node, and metastasis, how the cancer is involved in each of these categories. And I'm not going to go into the details, but I wanted to just teach you that that's how we as physicians really think about this. So T refers to the primary tumor. It involves depth of invasion, the size of the tumor. N refers to regional lymph nodes, whether they're present or absent, and sometimes is defined by the number of lymph nodes. And then M refers to distant metastasis, again, whether it's present or absent, and there are some nuances. And we combine those T, N, and M to come up with an overall stage, which you can see kind of in this top right corner. Table 2 allows us to come up with that combined stage. I'm going to really let Dr. Klimstra go into the details of understanding your pathology, but suffice it to say that this has really evolved over the last 30 or 40 years. We think about differentiation, which is really what the cells look like under the microscope, grade, which is how rapid they are dividing, and there are a number of features that help pathologists determine this. And then that in turn helps oncologists, both medical oncologists like myself and surgical oncologists, tailor the treatment based on a number of these characteristics. A key takeaway, and I would imagine that Dr. Klimster will touch on this, an expert pathology review is just as important as getting an expert medical oncologist or expert surgical oncologist or even radiologist. So really having people who are familiar with these cancers is critical. Understanding your PET. So we talked a little bit about stage and determining extent of disease. So DOTA PET scans are really one of our best tools to help determine extent and volume of disease. Again, I know Dr. Fakhri will go over this, but just to give you a little bit of a teaser, you can see really big differences in these three different DOTA PET scans. This first one is localized. The middle one is metastatic with high volume, large liver lesions. It's liver predominant. And then on the far right, the patient has metastatic disease, but it is lower volume, but lots of little scattered bone metastases. So PETs give us incredible resolution and really, again, help us tailor treatments. Dr. Kunstman will touch on surgery. Really, one of our first steps in tailoring a treatment for a patient is asking this question: is surgery feasible? The answer is yes for several situations. If it's localized, we can often offer curative intent surgery to remove the primary tumor. If it's metastatic and patients have symptoms from their primary tumor, like a blockage, we sometimes will still remove that primary tumor. And if metastatic with low grade or low tumor burden, we sometimes even can offer surgical removal of some of those metastatic sites, which we call cytoreductive surgery. If the answer to is surgery feasible a no, that often will happen for patients who have high tumor burden or if it's high grade, or just if a patient is not a good surgical candidate. And then we will think about doing systemic treatments. So systemic treatments fall into kind of the realm of a medical oncologist, and they fall into 5 main treatment categories. Somatostatin analogs, many of you have heard of these monthly hormone injections. They don't have anything to do with male or female hormones, but involve hormones that are related to net tumor growth. So octreotide and lanreotide are 2 examples. There are targeted therapies such as everolimus and sunitinib. We actually have a new one called cabozantinib that was just FDA approved. These target very specific tumor growth pathways for neuroendocrine neoplasms. There's true chemotherapy, and there's a range of different chemotherapy options. There is immunotherapy, generally only reserved for patients with higher grade, poorly differentiated neuroendocrine carcinomas, and I'm happy to answer some questions on that in the Q&A. And then one of our newest, maybe not even that new, FDA approved in 2018, but newer category of treatments is something called radioligand therapy. And this really takes advantage of knowing that we have that somatostatin receptor on the cell surface from the PET, and then we target a therapy to that receptor, that target, that is a radioisotope, in this case, lutetium-177, but we have several clinical trials looking at new radioisotopes. So systemic treatments, just as I was saying earlier, we are splitters now and think about pancreatic nets differently than small bowel nets. So our systemic treatments differ by primary site. So it's important for us to try our best to figure out where your tumor originates. There are still some situations that arise where we can't figure that out, and there are some treatments that actually can apply to several different primary sites. But often for starters, for lower grade neuroendocrine neoplasm, we will use observation if it's slow growing and patients are asymptomatic, or consider octreotide or lanreotide. For pancreatic nets, we have several options, including some of those ones I mentioned. For small bowel net, there are actually fewer options than for pancreatic nets. Chemotherapy does not work as well for small bowel neuroendocrine tumors. And I want to just highlight that the NCCN, or the National Comprehensive Cancer Network, puts out guidelines for physicians, but there's also a patient portal that is very helpful and describes these algorithms that we rely on as doctors, and puts them into lay terms. And they are specific for each primary site. Really critical to thinking about systemic treatments and really moving the needle forward is thinking about clinical trials. We have several clinical trials for neuroendocrine tumors and neuroendocrine carcinomas at Yale at present. I want to just mention a few. So this first one in the table is for patients who've had a pancreatic net removed, and we're asking the question, does 4 months of capecitabine temozolomide chemotherapy help reduce that risk of recurrence? This second row is a new trial looking at lutetium dotatate. That's the radioligand therapy kind of earlier in the disease course. So this is a first-line treatment for patients with grade 1 and grade 2 GI neuroendocrine tumors. We also have a new trial that's just opened looking at symptom control. I mentioned that some patients with NETs, about 30 to 40%, may secrete hormones. And there is a new oral form of octreotide called paltusotine, and we are looking at that for carcinoid syndrome. And then for neuroendocrine carcinoma, we have 2 trials. One is looking at the combination of chemotherapy and immunotherapy. That's atezolizumab. And then a new kind of earlier phase trial that's looking at a very exciting new target called DLL3. And this is paluntamig, which is a new drug that's being studied both alone and with chemotherapy. So I really like talking about the advances that we've made. As you can see, all these advances are clustered on the right side since 2011. And I think that these advances really make me hopeful for the future of this field. I think they impart hope to patients. I think we're doing lots of exciting work in clinical trials, and hopefully we'll have some new treatments available in the next couple of years. I think also as patients and caregivers, it's important to arm yourself with information. This is just an example from LACNETS, and which is a patient advocacy group, and they have something called Net Vitals, which is a wonderful tool to help you learn what questions to ask your doctors. So a few parting thoughts. So primary site matters for treatment selection. Stage indicates where the cancer is located, and grade refers to biology or degree of aggressiveness. Again, we've made several incredible advances in the last 10 years in terms of treatment and in terms of imaging, and clinical trials are really critical to make some progress in the field. And so I will stop share here. I am going to pass the baton to Dr. Klimstra, who will go next. And actually, what I forgot, what I do need to do is I will be playing a video. Dr. Klimstra is on, but we have pre-recorded his video. So bear with me for just a moment. Okay.
Here at Yale, and I'm very happy to share.
I'll start that from the beginning.
Good evening. I'm David Klimstra. I'm a pathologist here at Yale, and I'm very happy to share some information about understanding the pathology of neuroendocrine tumors. But first, a few words about pathologists. Pathologists are physicians that don't directly interact with patients most of the time, unlike gastroenterologists or an oncologist or a surgeon. They're essentially behind the scenes. And I sort of think of them as being behind the curtain. If you remember The Wizard of Oz, and the little dog opens the curtain, and there's a statement, pay no attention to the man behind the curtain. Well, pathologists are often behind the curtain, but I think we should pay attention to the man behind the curtain, or perhaps the woman behind the curtain, because pathologists have a lot to contribute to the knowledge about your disease. So what is pathology? If you Google it, this is the definition that pops up. Everything is AI these days, and it says pathology is the medical science that studies the causes, mechanisms, and effects of disease. It involves examining tissues, fluids, and organs to identify and understand the underlying causes of illness. Typically, we do this using a microscope, looking at glass slides of tissue, but increasingly we're using genetic sequencing and other more advanced technologies. In practical terms, what does pathology provide for the patient? Well, pathology establishes the diagnosis of a neuroendocrine tumor. It can help identify where the tumor originated if it's not immediately apparent. We can assess the adequacy of a surgical procedure to remove a neuroendocrine tumor. We can also look at factors that predict how aggressive a particular tumor is likely to be. We study factors that predict responses to treatment. These are known as biomarkers, and we can even analyze the risk for hereditary disease. So if we think about neuroendocrine tumors, just some general principles, and neuroendocrine cells are cells that produce various types of hormones, and they're distributed throughout most organs in the body. Essentially everywhere there are neuroendocrine cells, and therefore neuroendocrine tumors can arise in these various organs throughout the body. And we call them neuroendocrine tumors or NETs. This is a relatively recent standardization of the nomenclature. In the past, they were often called carcinoid tumors. And in the lung, even now, that term is commonly used. So it's important to know that NET and carcinoid tumor are synonymous. Now, in the spectrum of cancers, and NETs are regarded to be cancer, malignant, neuroendocrine tumors are considered well differentiated. Now, what exactly does that mean? Well, differentiation has to do with how closely a tumor resembles its normal counterpart. So for instance, if we look at a piece of pancreas and there's an organ called the islet of Langerhans composed of normal pancreatic neuroendocrine cells, And if we look at a pancreatic neuroendocrine tumor, you can see that the tumor cells look very similar to their normal counterparts. This is what's known as well differentiated. In clinical terms, this equates to a relatively slow growing tumor, which is good news. It means that neuroendocrine tumors are not as aggressive as other types of malignancy. That being said, some neuroendocrine tumors are more aggressive than others, and predicting which ones are likely to be more aggressive is an important role for pathology. It's also important to remember that the proper treatment depends on quite a number of different factors. It depends on where the neuroendocrine tumor originated, how aggressive it is. In other words, is it a relatively slow, benign behaving neuroendocrine tumor, or is it a more aggressive, malignant behaving neuroendocrine tumor? Also, how advanced it is. Is it still localized within the organ where it originated, or has it spread? And furthermore, what genetic abnormalities it has can be important to help direct treatment. Now, neuroendocrine tumors have been increasing over the past decades, and you can see this is a comparison that shows the top line for all malignant neoplasms is relatively flat, whereas the red line for neuroendocrine tumors has been increasing year to year, which means that they're becoming much more prevalent and important for us to recognize. So how do we establish a diagnosis of a neuroendocrine tumor? First of all, there has to be some suspicion, either from some symptoms the patient may be experiencing or from some finding on an imaging study. And then typically we try to obtain a piece of tissue to make the diagnosis through endoscopy or through interventional radiology using a needle or even through surgery. And all of these procedures give rise to a biopsy or a tissue sample, which is then sent to the pathology laboratory. We make this tissue into glass slides that are stained so we can look at them with a microscope, and this is what we see. These are neuroendocrine tumors viewed through a microscope. So this is the histology of neuroendocrine tumors. The image on the left is from the small intestine. The one on the right is from the pancreas. And if you look at this, you can see a number of different cellular structures that we pay attention to. You can see the cells have cytoplasm, which is stained pink. They have nuclei, which are stained purple. They also have, in this case, these dark pink hormone granules, which are recognizable. And all of these features are very characteristic pathologically when we look at them in the microscope. Some of the nuclei have this very coarse pattern in them, which is known as salt and pepper chromatin. You can imagine if you were to combine salt and pepper together, you would have a similar appearance. And this is so typical of neuroendocrine tumors. And the other feature is the fact that the cells tend to be arranged in nests. So all of these findings, when we look through a microscope, are able to suggest that we're dealing with a neuroendocrine tumor. But how do we confirm the diagnosis? Well, there's the characteristic microscopic appearance, which by itself can be very, very suggestive. But there's also techniques to demonstrate even more specifically that the cells we're seeing are represented neuroendocrine tumor. It turns out that there are very specific proteins that are characteristic of all or most neuroendocrine cells, and we can actually detect these proteins. How do we do this? A procedure known as immunohistochemistry. It's not actually that complicated. It involves using antibodies, which recognize very specifically these proteins. And the antibodies are tagged with a colored product, in most cases a brown color, that we can see through the microscope. So if we have a piece of a biopsy, we can apply these antibodies to it. And if the proteins that are characteristic of neuroendocrine cells and neuroendocrine tumors are present, they will stain brown, like this. And these are two of those proteins, chromogranin A and synaptophysin. And by applying this technique, we're able to verify that the tumor we see that has a microscopic appearance of a neuroendocrine tumor, in fact, has the proteins we expect to find in a neuroendocrine tumor. This is a very standard technique applied in pathology for many different tumor types and many different applications. Another example is that we can try to identify the site of origin of a neuroendocrine tumor if it has spread to a distant organ like the liver and it's not clear where it's coming from. And this is the list I showed you before of all of the different neuroendocrine tumors that can occur. And it turns out that we have antibodies that stain each of these different tumor types very specifically. So for instance, we have specific hormone markers that can be used to identify tumors from some locations. And we actually have other markers for different proteins that are specific to other sites. And so by using these stains, we're able to characterize the origin of many neuroendocrine tumors. What about assessing neuroendocrine tumors after surgery? If you're having surgery for a neuroendocrine tumor, the hope is that you have removed it. And one of the roles of pathology is to look at that specimen and determine whether or not the tumor has been completely removed. This involves looking at the margins or the edges of the tissue. And if the tumor has been completely removed, there should be normal tissue at the edges. On the other hand, if the tumor has been incompletely removed, it may extend to the tissue edge. And by seeing that, we can recognize that the resection of the tumor has not been complete. Another thing that we do with surgical specimen is look at evidence of spread. Has the neuroendocrine tumor spread from its primary site to distant sites or lymph nodes? And typically lymph nodes are removed at the time of surgery, and sometimes also biopsies of distant sites will be provided for us to assess the extent of disease. So how do we predict the aggressiveness of neuroendocrine tumors? Well, the first is what I just said. We look at the stage, in other words, the extent of tumor. How big is it? How deeply invasive is it? Has it spread to lymph nodes or distant sites? And each of these different parameters correlates with increasing aggressiveness as it moves from the local organ into other distant sites. But another very important parameter is to establish the grade. And what the grade refers to is the inherent aggressiveness of the tumor. Is this a bland, mild tumor, or is this a real bully? And we have a way of measuring that. And it's actually based on the growth rate of the tumor, which makes sense. The faster it's growing, the more aggressive it is. So how do we measure the growth rate? Well, for a tumor to grow, the cells must divide. They go through the process of mitosis, where one cell replicates its DNA and then splits into two cells. And this process of mitosis is visible microscopically. So if you look at cells, you can see the condensation of the chromatin or the chromosomes, I should say, in the middle of the cell. And these mitotic figures, as they're known, can be found within neuroendocrine tumor samples. And so by looking at the histology of the neuroendocrine tumor with a microscope, we can find these mitotic figures and we can quantify them. And they're typically expressed as the number of mitoses in a certain area of the tumor. 2 square millimeters is typical. Another technique we can use to assess the growth rate or the cell divisions is again by immunohistochemistry. And there's a protein called Ki67 or Ki67, which is expressed in cells that are growing and reproducing their DNA. And it results in brown staining of the nuclei. And the more brown staining you have, the more rapidly growing the tumor is. We express this as the Ki67 index, or the percentage of tumor cells that show brown staining. And it turns out that the World Health Organization has established a grading system for neuroendocrine tumors that is based on both the mitotic rate that I mentioned and the Ki67 index. And you can see that as the rates of proliferation, growth of the cells go up, the grade goes up correspondingly. Here's a comparison of the Ki67 staining for a low grade or G1 net, an intermediate grade or G2 net, and a high grade or grade 3, G3 net. And you can see the dramatic change in the number of the nuclei that are staining brown. And this is a very commonly used technique to establish the grade of neuroendocrine tumors. It turns out that the grade correlates very well with clinical outcome. So if we look at, for instance, this study of patients who have metastatic neuroendocrine tumors, those that have spread to distant organs, the ones that are low grade still have a very good survival. The top line shows that nearly 90% of those patients are still alive after 5 years. But as you get into intermediate grade, the green line, or high grade, the orange line, you can see that that survival declines from 50% to very low over the course of 5 years. And so grading, it turns out, is a very essential pathologic parameter that we have to assess. Now, I mentioned before that we're also doing genetic sequencing of neuroendocrine tumors, and this is, again, a fundamental aspect of the pathology. How is this useful? Well, it can help verify the diagnosis. There are certain mutations that are highly characteristic of neuroendocrine tumors, and so if we find those mutations by sequencing the tumor's DNA, it can help support the diagnosis of neuroendocrine tumor. It can also predict the outcome. Some of these mutations are associated with the prognosis, and so finding a certain mutation may tell you that this tumor is likely to be more aggressive than another neuroendocrine tumor. Probably the most exciting feature of sequencing the tumor DNA is to identify mutations that we have drugs for. So some of the treatments you may be offered for neuroendocrine tumors act by targeting specific mutations. And we can find those mutations that will predict that that drug will work in that given tumor. And this is what's known as precision medicine, a very exciting current way of managing patients. And finally, if we look at not the tumor DNA, but the normal germline DNA, we can identify if there's a risk of hereditary disease. Now, this is very important because if the cancer is arising because of a hereditary mutation, it means other members of the family are also at risk. And just for example, in pancreatic neuroendocrine tumors, there's a whole list of hereditary associations. These are inherited diseases that give rise to neuroendocrine tumors. And by sequencing the germline DNA, the normal DNA, we're able to recognize these to help identify patients with a family risk. Up to 16% of patients with pancreatic neuroendocrine tumors have a hereditary cancer predisposition mutation, and so this is very important. So just to summarize, pathologists provide some of the most vital information to establish the diagnosis, predict the clinical behavior, and predict response to specific treatments. But it's important to remember that pathology is an interpretive discipline. Some aspects are subjective, and this is the interpretation of an individual pathologist. So this little cartoon, which I've shamelessly stolen off the internet, says, good, you've got the pathology report. What did the lab say? And the response is, as though it was a dog wolf. Because the lab isn't saying anything. It's the pathologist who wrote the report that is conveying the information. And so you have to understand that just as any other physician gives an opinion, the pathologist is giving an opinion on the pathology. Now, many aspects of it are quite black and white, and you should be able to obtain the definitive diagnosis, the results of any immunohistochemistry, the site of origin of the cancer, the stage, the grade of the cancer, and the results of any genomics or biomarker studies. All of these should be conveyed within a pathology report, and you should look for this information if you see a pathology report on a neuroendocrine tumor or really any kind of cancer. And if there are any doubts about the pathology, the physician treating you is a little uncertain, or you have concerns, it's always possible to get a second opinion. Pathology cases can be sent to experts in neuroendocrine tumor pathology to ensure that everything is done correctly. So with that, I hope you've learned a little bit about what pathologists do in the care of patients with neuroendocrine tumors, and I'll be happy to participate in the discussion in a little while. Thanks so much for listening.
Wonderful. So Dr. Klimstra will be available for the Q&A. I'll just remind everybody that the Q&A will be done through the Q&A webinar tool. You're welcome to start putting things in if you had questions either from my presentation or Dr. Klimstra's, and we can start answering some of those, but also can take those questions live. So Dr. Fakhri, I will pass to you.
Thank you, Dr. Kunz. Hello, everyone. It's a pleasure to join you here. I joined Yale only 2 years ago, and I lead there the Yale Biomedical Imaging Institute and the Yale PET Center. And what we're going to talk about is understanding your PET. And your PET in this case, I'm sure you all know by now, that's positron emission tomography. That's not your PET at home. So how does positron emission tomography work? If you've had a PET or if you Googled one, you'll see that usually we will inject you with a radio tracer. And that radio tracer goes everywhere in your body. And then it's going to be a radioactive material that is going to be emitting some positrons. These positrons will annihilate, and we will have photons detected. So you'll have something like this, where you have some annihilation inside the body, 2 photons detected, and that tells us where that happened. Then we will have literally millions of these that we will be mapping back to where they were originated from. And that will give us a map of what the PET scan looks like. And these are the kind of typical PET scans you would see with if you're coming with suspicion of a neuroendocrine tumor. We're going to talk a little bit later about what dotatate PET is, but just to give you a sense, you will see things that are very abnormal. Here, this is disease or tumors. There are also a lot of normal things we'll see, like the kidneys or the bladder or physiological GI or GU, intestinal uptake, gastrointestinal uptake. We'll see also the pituitary gland that tends to light up on dotatate. So what our job is to, when we're doing the imaging, is to parse out what is normal uptake and what is abnormal, because the abnormal is what we are looking for, what we're interested in. Not that the normal is not important, but what we're looking for is the abnormal uptake. So how does that work? Dr. Kunz mentioned this earlier. What we're looking at here is something that is very specific in neuroendocrine tumors, which is that they express, especially as we go for high-grade tumors, they will express levels of a receptor called the somatostatin receptor. For those who are buffs of biochemistry, that's what the somatostatin receptor looks like. And this is very tempting for us in PET, because if we know what a structure is, we could make up something like a GPS that will hone on that somatostatin receptor, and that will be emitting back to the scanner where it is. And that's exactly what we do in a PET scan of a neuroendocrine tumor. We have injected a compound that is binding to the somatostatin receptor. That compound is, and the binding, I'm not going to bore you with the details, but usually we do some chelation, some form of chelation where we have an emitter that's usually either a SPECT emitter like indium or gallium for PET, or later we're going to see a little later what we're going to do with this when we do treatment with lutetium, because we're going to treat with the same thing. But for now, let's concentrate on the imaging side. That molecule now is bound to that tumor, and it's telling us, here's where I am. And that is very helpful because that will tell us something that is very specific about neuroendocrine tumors that is not something that will be shared with other uptake or tumors. So, for example, you may have had in the past another form of PET scans called FDG, fluorodeoxyglucose. That's by far the most widespread that we will do. 95% of all scans we do are FDG scans. Well, that doesn't work very well in neuroendocrine tumors. I'm showing you here an example where on the FDG PET, there's nothing abnormal here. Whereas you can see, you don't need to be really a radiologist to know that this is abnormal. There's clearly an abnormal uptake here that is related to the somatostatin receptor. So that side of the imaging, looking at the somatostatin receptor, is incredibly important because it's going to tell us, what is the tumor avid? If the tumor is avid, that's a good thing, because when we're going to hit it later with a beta emitter for therapy, well, we'll be able to do some damage, which is what we want to do. There have been several trials, many led by Dr. Kunz, who's here. The NETTER-1 trial was the one that led to the approval of lutetium dotatate. We're going to talk a lot more about this in the next slide. The NETTER-2 trial expanded the use from a second line of therapy that was in NETTER-1 to a first line of treatment for the high-grade disease. And the NETTER-3 trial, which is about to start, and Dr. Kunz is one of the two chairs of that trial. She's leading that trial. Is for low, and now we're moving to low-grade disease. So you see, we're going further and further upstream from the second line high grade, first line high grade, and now lower grade. So what are we doing there? Until now, we talked about the PET side of things where we image the patient. But the same way here, we chelated a gallium or an indium to image. Instead of that, we could chelate a lutetium. And now we got ourselves a beta emitter that can do some serious damage, whatever it's going to be. And if this molecule were to go only to the somatostatin receptors and nowhere else, you know that's not true, because I've showed you that some goes to the bladder, and we're going to come back to that, and some goes to the kidney. So we have to be careful with the organs, normal organs, which we call at risk. But if we have a lot of that going to the disease, like here, and if we're going to inflict some serious damage with lutetium-177, we got ourselves a treatment. And not only we got ourselves a treatment, but we got ourselves a treatment where we can see what we treat and we treat what we see, which is something that is incredibly important. That's a first that has been only a few years that we have. The only treatment we had in that space was iodine, and that was since the 40s for thyroid cancer. We haven't had anything since iodine. So, and Salhertz. So now we have two of these, one for prostate and one for neuroendocrine tumor. And unlike chemotherapies where you basically treat blind, you're bombing everything. Here we see where we're going, we see where our agents are killing tumors, and we can image them afterwards to see if there's still a lot of the tumor or not so much that is left. So theranostics is this combination where we're going to do at the same time diagnosis with PET, respect, and then therapy with a beta emitter, or later we'll see with an alpha emitter. And while the antibody drug conjugate deliver chemotoxins, here we're going to be delivering ionization energy to tumor cells to break the DNA and just kill them off. And then we reduce with that the off-target radiation effect, because we're killing where the tumor or where the molecule went, and we're not killing anywhere else. So the toxicity is going to be a lot less than if we're not selective. Since the first radiopharmaceutical drug has been approved, there's now FDA approval, as Dr. Kunz mentioned, for these. And the radiopharmaceuticals are gaining recognition as a viable target. So this is something that we are very excited about. All right, now all this is good and great. We could stop here. Unfortunately, or fortunately, each patient is unique. Each cycle in the treatment is unique, and each lesion is unique. What I mean by that is every patient will have a unique tumor burden and distribution. Uh, and that is going to be also changing at every cycle. Think of it this way. If this didn't change from cycle to cycle, it means the therapy isn't working. It's not doing anything. So it is a good thing that it's changing, but it's something that we should be taking into account. The paper that I'm showing here on the slide shows you the what we call the sink effects, which exacerbates this during the treatment. What this means, the sink effect means, is that the more the tumor is going to take up the treatment, and the less of that molecule will be available to circulate for the normal tissues, which is a good thing for us. And it shows you here that in the scatter plot that the tissue uptake, or SUV, right, decreases as a function of the total lesion burden or total lesion uptake. So the more the lesions take up the tracer, which is either the treatment or the imaging, and the less of the uptake is in the liver or in the parotid gland. And remember, I showed you some of those, kidney and spleen, which are the organs at risk that we want to preserve. So this reinforces the idea that instead of giving everybody the same dose, which is what we do now, we could give maybe higher doses to start because they could be tolerated in the beginning when the tumor burden is largest, and then there's the most sink effect. And then as we go down the treatment path, well, we reduce that dose. So this is one way we can individualize our treatment to lesions. We can personalizing the treatment also, lesion personalization matters. So not only patient personalization matter, but lesion personalization matter. You see here that the PET uptake, what we call the standard uptake value SUV, the PET uptake is significantly correlated with the SPECT uptake that we can see during the treatment. But there's a lot of variance, all right, which is what we just said. You know, every tumor is unique, every patient is unique, every cycle is unique. But you can see intuitively, you could understand here that the tumor control appear to be a function of the absorbed dose. Why? Because the more you absorb dose and the more you're likely to kill the tumor. So we do want to have an absorbed dose that is maximized because that will give us the best tumor control. You can see also here that for the higher absorbed dose, there was higher, better outcome than for lower absorbed dose. So how do we quantify this? How do we maximize this? Well, this makes the point that we should aim to tailor the treatment to maximize dose for all tumors, not just the average tumor, not one of the average tumors, but for each tumor alone. And the only way you can do this is by imaging, because remember, when we do imaging, we see all those tumors one by one, and we see what is the uptake in each of them. So the higher the tumors, and the more likely we can give a higher dose to start. And you know, it's worth noting also again that these numbers are on the low side, meaning that you know there is room to increase within reason our treatments. So how can we do this? This is something that we are actively working on with Dr. Kunz to try to personalize the treatment planning for radiopharmaceutical neuroendocrine therapies. And Yale Radiology and Radiation Oncology and the Cancer Center are collaboratively working on this. The idea is the following. If I do my pre-treatment of gallium dotatate, I have a good idea of what my tumors, or where my tumors are. I can define the targets. I can define the sensitive organs, and I can try to then extrapolate from this imaging what would the dose be for each of those. And I could put bars and thresholds on. I'm not going to allow more than a certain dose to the bladder. I'm not going to allow more than a certain dose to the marrow, to the liver, to the pituitary gland. And with that, what is the maximum dose that I can do then for my tumor? And then I can try to hit the tumor with a lot more than a standard dose of 200 millicurie per cycle for 6 cycles. So in a way, we are tuning the dose to maximize tumor killing while minimizing the side effects to the organs at risk. Great. I could do this at every cycle, but you can imagine that, and you are probably the best who can imagine this, that this is going to take a lot of effort on our part, but also on your part. Because now we're talking about you're getting not only a PET scan, but also getting SPECT scan at 4 hours, 24 hours, 48 hours, 72 hours to see, well, how is the activity changing in your body? What is the dose that you're getting for the tumor? What is the dose that you're getting for the lesions, for the healthy tissues, the organs at risk? But this is a good start because the pre-therapy is giving us a highly predictive indicator of the patient response. And this is now a standard that we use for patient selection to decide who qualifies and who doesn't. And I'm showing you here a patient, and this is where there's a lot of hope, where you see this is the patient scan after 1 cycle, after 4 cycles, and you can see that the activity is decreasing. And this is one where we started with 1 millicurie, where we escalated and then went down again. So there's hope. There's also a lot of work we're doing in my lab to try to avoid some of what you would have to go through to have every single dose measured, so have multiple scans. And the idea here is using artificial intelligence and networks to from our pre-treatment and 1 or 2 treatments predict the next treatment. So instead of having one size fits all, we use a wealth of data from the pre-dose PET and plenty of scans of plenty of patients that we've scanned before you to say, well, your PET scan fits best as this person, like a digital twin of yourself. And this is how these guys, all these girls did when we treated them with this dose. And that gives us a good indication as a predictive dose distribution of what we should be doing. And then, of course, we do cross-training and validation of these. So here's an example, and I'll finish with this. This is an example of one where we did the first dose, and from the first dose, we predicted what the second dose is, and then we compared to what we measured in the second dose. So we did the first dose, and we measured it. We did the cycle 2, again, second cycle of treatment, we measured the dose. But then we used only the first dose in our artificial networks to predict what the second dose would be. And the error you see is mostly in the bladder, which is the least of our worries. So our prediction for the tumors was very good. So we really hope that this predicting from 1 cycle what the next cycle would be a huge step to personalize the treatment without increasing too much the burden on the patient, and making a more of a personalized treatment for every patient. This is all I had, so thank you for tuning in, and I'll turn it back to you, Pam.
Great. Thanks, Dr. Fakhri. So we will finish up with Dr. Kunstman talking about surgery. So hopefully our audience can start thinking about questions and start putting them in the Q&A. So John, we'll turn to you.
Everybody hear me?
Yes.
Great. Okay. Let's see here. All right. Everybody can see my slides, I hope. All right, so hi, I'm John Kunstman. I'm a surgical oncologist at Yale. Happy to be chatting tonight about neuroendocrine tumors, one of my favorite surgical topics. So for my portion of the discussion, really 3 objectives that we want to get across is what are the indications for surgery? I'm going to try to not be too duplicative with Dr. Kunz, but I did want to spend a moment talking about other times when neuroendocrine tumors can actually forego surgery, even though they might be operative candidates. What are the options for surgery? And we're going to really focus on 2 paradigms, one being pancreatic neuroendocrine tumors and the other being enteric or intestinal neuroendocrine tumors, the 2 most commonly encountered in our practice, and then also learn what role surgery can play in the setting of metastatic disease. So just to remind you, for pancreatic neuroendocrine tumors, I know this is touched on before, the broad classifications that are relevant for surgery are those pancreatic neuroendocrine tumors that secrete hormones or functional tumors. Some of those are more aggressive, others are more indolent. But most cases that we diagnose today are non-functional. In other words, they're not secreting any hormones that we can detect. And most cases in such diagnoses are incidental, although some patients can have discomfort, weight loss, pancreatitis associated with their lesion. Treatment of pancreatic neuroendocrine tumors is very stage specific. So the first question, as alluded to by Dr. Kunz, when we make a new diagnosis is whether or not this tumor is localized to the pancreas, or has it spread to other organs. As I'll talk about a little later, even in stage 4 disease, surgery potentially with curative intent is still appropriate in some cases, but we'll come back to that. But for localized PNET, in other words, a case where the tumor is localized only to the pancreas, surgery is the primary treatment modality. We almost always will resect functional PNETs. Again, those are those hormone secreting PNETs, and certainly any non-functional PNETs that are symptomatic. Some cases can involve some other critical structures, what we call locally advanced tumors. These have previously been called unresectable. Sometimes they truly are unresectable, but we've been able to devise ways to offer surgery to many of these patients. And also, in other special cases, those that are associated with genetic syndromes, as alluded to by Dr. Klimstra, but we're not going to necessarily touch on those tonight. For people that have their PNET diagnosed incidentally, which again is the majority of patients these days, we try to make a determination about whether it's, the more or less aggressive behavior based on some of those factors here, so some other ones as well. You can really see why that pathologic assessment is so important in these in making those treatment decisions. I think, boiling it down though, the thing I always try to describe to patients is that all PNETs are cancers and they have the potential to grow and spread. It just so happens that the likelihood of spread is extraordinarily low in a certain subset of pancreatic neuroendocrine tumors, which has given rise to this paradigm for observation that we've seen. And this has really come about, I'm going to go through this kind of quickly, but this has really come about in the last 10 to 15 years with a number of case series, and there's some newer studies as well that shows that patients, that undergo observation, if they're carefully selected, they actually have, oftentimes no change in their overall outcome as to patients that go straight to surgery. So this has really become kind of the new mindset for patients with small, asymptomatic, non-functional, incidentally discovered pancreatic NETs. So the question about, are some safe to observe? Well, the answer to that is yes, but who are they? As I said, they have to be asymptomatic and non-functioning, in other words, not secreting a hormone in excess. No evidence of spread to the lymph nodes or elsewhere. A well-differentiated pathology, in other words, one that we believe will behave a little bit more indolently. Generally speaking, a small tumor because it's less likely to spread without us understanding it. And also, I think probably the most important thing is the patient has to be amenable to surveillance. What does that mean? Both follow-up and scans to make sure that this tumor doesn't grow and spread. So if all those criteria are met, we can and do observe some of these. But when we take patients to surgery, what are our goals? For me as a surgeon, obviously I want to maximize the control of the tumor, and by that I mean remove it, and have Dr. Klimstra come back and tell me that those margins are completely clear and it's been entirely removed. And we want to remove the lymph nodes along that area as well, because we don't know usually before surgery whether or not any of those lymph nodes carry disease, and we certainly want them out of the body. The overall goals are to prolong survival and also improve quality of life, especially in the cases where the tumor is symptomatic or metastatic. But we also want to minimize the risks of surgery. And by risk, I mean complication. You can see some of the complications there that we watch out for. Each are sort of individualized and unique in terms of how we mitigate them. But in terms of what operation we choose, it really depends on where the tumor is and how much lymph node harvest and really what kind of comorbid conditions or other medical conditions a patient may have. Certainly some patients may not be a candidate for a very extensive operation, and we may look for non-surgical alternatives to treatment. The simplest operation we do is something called enucleation. That's really just taking the tumor out of the pancreas itself. You can see it's not quite as easy as the cartoon suggests, but it really is just removing the tumor itself while leaving all of the pancreas behind. It does have a very low complication rate, but the problem with that is it's really only correct for the most indolent and small tumors. Insulinomas are the kind of classic example. You can see a pathology specimen there, what it looks like when it comes out. It also has to be away from the pancreatic duct so we don't get a pancreatic leak after surgery. Um, most patients are not candidates for enucleation. Again, the main thing is the tumor location. But mostly, and what I'm going to talk about today is two main procedures, what's called a Whipple procedure, a pancreatic duodenectomy for tumors in the head, and then a distal pancreatectomy for tumors in the neck or body. Is it safe? Especially when people talk about Whipple procedures, they may have heard that or Googled that or heard about it from a friend or a TV show. The bottom line is it is a big operation, and even a distal pancreatectomy is a big operation. But at the same time, at centers and with surgeons that have experience in high volume of patients, it can be done safely and it can be done with a reasonable risk of complication. For instance, here at Yale, these numbers are a year or two old, but we do about 100 pancreatic resections a year. That number has gone up in the last 2 or 3 years. And we've also developed a number of things here at Yale to minimize risk of complication. The mortality for a Whipple procedure, for instance, used to be considered to be 3% or less was a good number here. It's under 2%. The length of stay has gone down. At Yale, again, the risk of complication, is better than the 90th percentile nationally. So a distal pancreatectomy, which is oftentimes the treatment of choice for a neuroendocrine tumor, it's for tumors that are located in the body or tail of the pancreas. It can be done open, it can be done laparoscopic, it can be done robot assisted. We do all of them here at Yale. We certainly favor a minimally invasive approach in most patients. That are candidates for it. Removal of the spleen is done on a case-by-case basis. You can see there in the cartoon, the reason the spleen is oftentimes removed is that the vessels, both the artery and the vein that go to the spleen, are oftentimes very, very intimately involved with the tumor. For adults, removal of the spleen has really no consequence in terms of your overall health. However, sometimes it can be spared in properly selected patients, but not really a concern that we worry about too much if that spleen needs to be removed. I'm going to put just a couple of surgical photos, so if you don't like the sight of organs, you may want to close your eyes for just a moment. But just to show you a picture, this is what it looks like when you perform a laparoscopic procedure. This is a spleen preserving procedure. You can see this staple line here is on the remaining pancreas, which is over here. The part of the pancreas that's been removed is right over here. Here's that splenic artery that's going along and the splenic vein that's going on, and here's the spleen. If the spleen needs to be removed, then these vessels are removed, but you can see all of the lymph nodes and tissue has been removed along there. This case was done in a minimally invasive way. So for PNETs, pancreatic neuroendocrine tumors, again, the goal of the surgery is to control the disease, increase the quality of life if we can, and do it with minimal complication rate. 3 operations are usually done, most frequently a Whipple procedure, a distal pancreatectomy, or an enucleation in rare cases. And again, the operation is dictated by the location of the tumor, and the outcomes really are excellent at high volume centers. I'm going to shift gears for the last few minutes to talk about intestinal neuroendocrine tumors. These can occur anywhere from your esophagus to your rectum, but most commonly they occur in the small intestine or appendix, what we call midgut neuroendocrine tumor. So it is the most common tumor of the small bowel. Some patients do present with obstruction or abdominal discomfort or symptoms from them. Sometimes it can cause a full-blown obstruction or what's called an intussusception, which I think there's a photo here. Yep, that's an intussusception there of some bowel. You can see that could cause a problem there. It's sort of like a windsock going inside out. But most patients are diagnosed incidentally. Patients that do have these tumors, the primary tumor actually tends to be rather small and starts in the intestines here. But when they spread to the lymph nodes, these yellow nodules here along the blood vessels, those lesions, the lymph nodes can get quite large. And those lymph nodes actually are oftentimes the source of the pain or discomfort or obstruction, or what's noticed on a scan that leads a patient to get the diagnosis. The staging of these patients, as before, can include testing, both labs, studies, biopsies. If possible, we want to try and understand the grade so we understand the best treatments. But the goal of all these, tests is to determine the resectability and again, whether or not there's been any spread. So you can see here, this teeny tiny thing here is one of these lymph nodes. Along the vessel there. You can see on the cartoon the matched set from the CAT scan there on the left side. But sometimes they can be quite large, as you can see here. Here's that same lymph node, much, much larger in this particular patient. And like I said, that's usually what catches the eye of the radiologist when you get a scan. And you can see sometimes they can be quite involved, including some major blood vessels and sometimes be quite a challenge for removal. Again, just like with the pancreatic operations, our goal is to remove the primary tumor. Oftentimes in these cases, there is quite a bit of lymph node spread or even multiple primary tumors in a third of cases. And again, if the patient is metastatic or symptomatic, we of course want to improve quality of life in the operating room. And as before, we want to minimize complications, different set of complications with these particular patients as opposed to the pancreatic surgery, but still something we watch out for. Here's just a couple of more surgical photos again, so you can see what I'm talking about. Here's somebody with multiple lesions in the bowel. You can see 1, 2, 3, 4, 5 there. And then on the picture on the right, you can see these lumps and bumps here, not necessarily in the intestine, which is on the outside, but these are those lymph nodes that the instruments are pointing to there. And that's all disease. So we need to clear that out if we're in the operating room. Just real briefly at the end, just want to touch on stage 4, metastatic disease, which oftentimes is in the liver, but can be in many other sites. In these operations, we do believe there's a survival benefit if we can clear the majority or all of the disease. Sometimes we can do that, other times, we can't, and we have to rely on systemic treatments. Most often in these cases, we actually use both. In other words, a patient might get a systemic treatment as a bridge to surgery or hopefully to reduce the size of the tumors in order to facilitate surgery. So there's a particular tumor in the liver, and then we remove that portion of the liver there, and so that patient was rendered free of disease again. So just in summary, as always, each patient should be managed individually based on how their symptoms and presentation go, and as their disease and the grade and whether or not surgery is the right choice for them. We always want to talk about these patients with our colleagues from medical oncology, radiation oncology to come up with a multidisciplinary plan. But when we do these operations, we need to, there's usually more than one site of disease, and we want to try and clear out as much as we can, preferably all the disease if we're going to the operating room and committing to surgery. And then, like I said, even in the setting of advanced or metastatic disease, some patients can still be treated with curative intent. In the future, we hope some of those newer drugs that Dr. Kunz was mentioning can help facilitate operative candidacy for more patients, including treatment that could downstage or reduce the size of their tumor to facilitate an operation, as well as image-guided surgery and some of those molecular targets that Dr. Klimstra mentioned. So I think that's my last slide. Here's my partners and our research staff. Thanks everybody for your attention, and of course be happy to answer any questions.
Thank you, Dr. Kunstman. Well, that was great. I'm going to ask my co-presenters to turn on video if they can. And we had one question come into the chat, and then I also have some other questions, but please, to our audience, feel free to put in your burning questions. So the first question is a really practical one. I know some of the answer, but I might ask Dr. El Fakhri to answer it. So how can we get pets faster? And maybe, George, you can speak to kind of newer pet modalities that are coming, but really the practicality of getting pets. And I think this really speaks to we are using them more. Buried on one of your slides was the fact that we are actually using this approach of getting pets and targeted radioligand therapy also for prostate cancer. We are going to see just an explosion of this pets and treatment combined in other solid tumors. So how are we meeting those needs?
Right. So we are, and somebody has asked also, how does that compare to a CT scan? I can try to answer that as well. So we are trying not to be victims of our own success. This is an incredible opportunity to be a lot more personalized to each patient. The difficulty is twofold. One is in terms of scanners, and we are putting in more scanners. There are new PET CTs that are coming to Yale New Haven Hospital, and some are up and running now. We are also working on more efficient scanners. One of the things that technology is available now is for full body scanner, where instead of having a 30 centimeter axial field, you have 1.5 meters. So that would be a scan in 2 minutes instead of 25 minutes. And then you can imagine you can do a lot more. We don't have one of those at Yale New Haven yet, but one will be coming to the Imaging Institute in 2 years from now, and we will be making every effort to have days available for clinical use. So that's the equipment side. The other side of this is the radiopharmaceutical, because as you know, most of the time we talked about gallium-68 dotatate, so that's a half-life of 68 minutes. So that means you can't make that in, say, California and then ship it over. By the time it's here, there's nothing left. So far we have been tributaries of, who is delivering those. We are also on that front working on making, there's a major effort happening at Yale to have a GMP facility that will be also in 3 years from now, 2.5 years from now, where we'll be able to make those compounds ourselves and then send them to the hospital so that we won't be tributaries where there's a snowstorm, which happens in the winter, or there's a strike, or there's a failure of synthesis. And we'll be able to do more of those and working on both of those. The question that was asked is, how does a PET compare to a CT scan? In 3 words, much, much better. Much better. That's 3 words. So in a PET CT, you always get a CT for free because there's a PET CT, it has a CT, a scanner, and a PET scanner. But to give you an analogy, and I think Dr. Kunstman had very nice CTs that were all obvious. These were like the ones, if you have this, there's nothing else you need. More often than not, that's not what we have. What we have is something where this could be a tumor, it could be something else. What you're looking at with CT is just a change in density, and that will happen sometimes in the tumor, but it can happen for all sort of other reasons. That is, so if you look at those images, the beautiful images that we saw from Dr. Kunstman, you can see like it has a different appearance and consistency. But then there could be all sort of other things that have the same changes in density. Whereas with PET, we're looking at the somatostatin receptor that will be only expressed when it is a tumor. So it's a lot more sensitive, meaning you can see a lot less of it, a lot more specific. It's only for tumors. You can see it on CT when you have a lot of the tumor present. That's probably about 1 million times. You need 1 million times more cells to see it on CT that you need on PET. So it's a lot more sensitive, but it's also a lot more expensive, a lot slower, and there are a lot fewer of them.
I would just add to, I would just add
I was going to
that.
ask you to comment on that, John.
Yeah. I would just add to that depending on the question that's being asked, the scans can be much, much better to answer one particular question versus another. So, patients that are being evaluated for surgery may need a particular type of CT scan or PET scan, or, depending on the question being asked. So for instance, as I was alluding to in those small bowel neuroendocrine tumor slides, many times these very infiltrative masses and nodes will be along the major vessels, and it's very hard for us to tell on a PET scan, which is lower resolution CT, as opposed to a dedicated CT angiogram or sometimes venogram, that will get to facilitate surgical planning. So it may be a different question that's being asked. It's not just that we're being sticklers. It's really to answer a very specific question. So for instance, the operation I just did today on a patient with a neuroendocrine tumor in the mesentery, it was critical that we understood how many branches of the intestinal blood supply were free, such that we could do the operation and preserve the intestines and the digestive function. So, that's the kind of specific question we may get a particular scan to understand.
And those are things that cannot answer because you're only seeing the somatostatin receptor. You don't see, think of it as, the Where's Waldo kind of cartoons. You'll see Waldo lighting up and you won't know anything around him. Whereas with a CT scan, you'll see all the anatomical details that are around you, but you may not see Waldo lighting up. So both of those are incredibly useful.
Yeah, all good. Dr. Klimstra, nice to have you live. I'm going to ask you a question. I know you focused primarily on the well-differentiated neuroendocrine tumors. I wondered if you could comment just briefly for our audience, what's a neuroendocrine carcinoma? We treat those very differently in medical oncology.
Sure. So yes, what I talked about was exclusively the well-differentiated category. And as I said, they can be low grade, intermediate grade, or rarely high grade. The neuroendocrine carcinomas are really not that closely related, even though the name sounds very similar. These are proper carcinomas that are more closely related to adenocarcinoma, squamous cell carcinoma, other types of cancer that can arise in the pancreas or the lung or the colon. They're very highly aggressive. They share the immunohistochemical staining that I demonstrated for neuroendocrine markers, but they differ in almost every other way. They're very, very highly proliferative, rapidly growing. They have a totally different spectrum of mutations, and they respond predominantly to different drugs, which of course you'd be much better to comment on than I. But so the distinction between the well-differentiated and the poorly differentiated is extraordinarily important. It can sometimes be challenging, but we're pretty good at it.
Yeah, thank you. That's great. I'm going to mention one thing that an audience member texted in or messaged in is this webinar available afterwards? The answer is yes. So stay tuned. Our team will actually send out a message with that link, and it will be available on our YouTube channel. So if you didn't take notes or if you want to send it on to family members or friends, this will be available afterwards. I'm going to tackle one of the questions in the chat. So one of those was, why wouldn't you immediately start treatment for a patient with a small intestine or any NET that is stable and non-functional but has spread to other places? That's an awesome question, and one that we actually talk quite a bit with patients about. So for patients who have a asymptomatic, maybe they were incidentally diagnosed, they came in for a completely different reason and were found to have a low-grade neuroendocrine tumor that is spread perhaps to the liver as a very common scenario. Why wouldn't we start treatment immediately? There is an option to either observe those patients and monitor very closely with scans, or to start perhaps on something like octreotide or lanreotide. The reason is many of those patients, you may have had that for years already, and we don't know the pace of growth. And if the tumor itself is going to remain stable, generally my recommendation is to monitor until we see clear evidence of growth. We are sparing you side effects of those monthly injections until the time that you really need it, where we start seeing some evidence of growth. Now, that is a difficult conversation, especially with a patient that's newly diagnosed, and we use shared decision making. And if it is really important to you to start something, we absolutely will have that conversation. And I really try to do that as a kind of a joint decision with the patient. So, Dr. Kunstman, there was a question that came in around stage 4 disease and the goals of surgery. Can we cure patients with stage 4 disease? And specifically the question is in a situation where the primary tumor is pancreatic and well differentiated and has metastasized to the liver, if you're able to remove those liver spots in the pancreas spot, how often do you see recurrence?
Yeah, it's a great question too. And much like everything in neuroendocrine disease, it depends. So, the scenario where we have, what Dr. Klimstra was talking about, a really well differentiated, low grade tumor. Actually, many of these with a single or maybe even 2 or 3 lesions can be resected, and patients can go for many, many, many years being free of disease, perhaps their entire life. Again, as Dr. Kunz was just alluding to, one of the challenging things is at the time of diagnosis, you don't know whether this particular tumor or tumors have been there for 6 months or 6 years or 16 years sometimes. So when we are operating in the setting of metastatic disease, I often use the analogy of sort of resetting the clock on patients. Yes, we still need to watch and basically watch them for life for any other signs of recurrence. But sometimes we can reset the clock to such a point and the pace of the disease is slow enough that they go through the rest of the natural life and, without any recurrence of disease. That can be a little more challenging in higher grade disease, grade 2, grade 3 disease. Recurrence is more often and is essentially the rule rather than the exception. At the same time, same kind of scenario, if we can knock the disease back considerably, there's also some evidence that some of the treatments Dr. Kunz can give work better in the setting of lower volume disease than higher volume disease. This is part of the reason, having a multi-specialty and multidisciplinary management team is so important. Is not only are these treatments tough to align, but they're sometimes really important to sequence correctly as well. In other words, what comes first, second, or third really matters. So I hope that answered the question.
Yeah, that's great, John. Thank you. So one of my favorite ways to end these webinars is really forward looking. I'm going to go around. John, I'll start with you since you've heard me ask this before. I really like asking, what are you most hopeful for? What are you most excited about in your field for NETs? So John, I'll start with you.
Well, I'll answer it the same way I did a few months ago. The thing that's most exciting to me, what really, really gets me out of bed in the morning, is taking tumors, neuroendocrine tumors, either of the pancreas or of the intestines, that some other institution or surgeon, or oftentimes surgeons, has said is unresectable, and turning it into something that's resectable. All of those, one of the best things about neuroendocrine disease is that it is moving so quickly. And some of the treatments that are coming out in the last few years and imminently can sometimes cytoreduce, shrink, or alter tumors in such a way that we can consider curative operations on patients that we never could have thought about that before. So that's what's really, really satisfying to me, and exciting in terms of what's next.
Great. Thanks, John. David, I'll go to you next. You and me, I will just acknowledge David has been in the neuroendocrine field and has really literally written the book on neuroendocrine tumor pathology books. And so you have seen the field evolve over many years. What are you most excited about?
It's a great question, Pam, and I think John Kunstman alluded to this a minute ago in one of the comments he made about staging treatments. We've learned so much about the pathology, the genetics of these various neuroendocrine tumors. And especially for some sites like pancreas, we now have many different treatment options. But I think it's still challenging to decide which one to try first in a given patient. You can correct me if I'm wrong about that, but I think we can use a lot more information about which treatments are most likely to be effective. And we're beginning to unravel this based on the fact that some treatments target specific mutational pathways, but a lot more study is necessary. And so what I get excited about is the possibility that we can discover ways to predict response to therapy that we don't have today, so we know which of these various approved therapies would be the best for each individual patient.
Thanks, David. George.
I would say, my answer is going to be on the theranostic side, but I think moving
Can you
earlier and
define,
earlier.
can you define that word for everybody?
Yes. Oh, well, if you missed the lecture or the presentation, so being able to use the same molecule to image and to treat, so that you can have a PET scan, you see where your somatostatin receptors are, and then you change one radioisotope from a positron emitter to a beta emitter, or better yet, alpha emitter, and now you are treating. Moving to alpha emitters is a huge promise. It's still not there yet, but because the cell kill will be much higher. There will be a lot more DNA damage. I think the other part that is very exciting, in addition to moving earlier and using theranostics, is combining theranostics with other treatments, because so far it has been done on its own. So combining this with other treatments that are already, that many discussed today, I think is another exciting area where hopefully we'll see better results.
That's great. I'll go also. So I have to say, as someone who's a clinical trialist and has been in the neuroendocrine space for a long time, I'm really excited about the attention that NETs has finally been getting over the last 5 to 10 years in clinical trials. We need data to really provide us with information on the best treatments to use, what order we can do them in, how to better select patients and identify patients. And when I meet with patients in clinic and I'm asked, well, what's the next best treatment? We haven't historically had clinical trials like our colleagues in colon cancer or breast cancer to say we have hundreds of patients that have been treated in this trial, and this is our best evidence or best data. And I think we're getting there. So I find that really exciting and very hopeful. I think that many patients who are alive now with NETs will directly benefit from clinical trials that are ongoing. And, with really help from this entire multidisciplinary team. And so I think a key takeaway is be sure you have some NET experts, whether they're NET pathologists, NET radiologists, or NET surgeons, or medical oncologists on your team. There are ways to get that regardless of where you live. And we work well with community oncologists and community team members to really try to help get you best of both worlds. So we are going to end there. This webinar will be available afterwards. Huge thank you to my colleagues for spending their evening, and happy NET Awareness Day. So thank you, everybody. Have a great night.